that was somehow came in between. That was change in diagnostics. But then tuberculosis in present scenario, the RNTCP was, it was evolved 90s, 95, 96, and because again political commitment, diagnosis by microscopy, essentially the radiology gone into the backdrop, and then adequate supply of dry drug, whatever the deficiencies found in NTP, then directly observed treatment was the source, and accountability, this record keeping what you should see today has came into RNT. And when RNTCP started, initially there was a three category of treatment. This was the first guideline by WHO, which was followed throughout the world in 2003, official guideline of RNTs. And there they started three categories of treatment. Category 1 was new smear positive pulmonary tuberculosis, seriously ill sputum negative pulmonary, like say TBM, like bone and joint tuberculosis with neurological complications. And this is seriously ill sputum negative, bilateral extensive disease, but you are not able to prove it. Seriously ill extrapulmonary, like TBM and I said, bone and joint tuberculosis. So that was category 1, and that was treated with intermittent regimen and with 4 drugs thrice a week for 2 months, and then continuation phase only 2 drugs, INH and rifampicin, thrice a week for 4 months. That was the standard category 1 in 2003. So sometimes when you take history and go back to this, then probably you have to ask these questions. Have you been provided daily treatment or intermittent treatment? That is the pointer. And then category 2 was, there was another category, and then category 3. Let me say first, category 1 was this new, and same thing if the smear negative, less serious forms of extrapulmonary TB and not seriously ill, they were categorized into category 3 initially. So category 1 was more bacteria, more serious disease. Category 3 was no bacteria, less serious disease. And difference between category 1 and category 3 was only initial phase, we have only 3 drugs. Here we have 4 drugs. Here we have 3 drugs, INH, rifampicin, and pyrazina. Again, thrice a week for 2 months, and then INH and rifampicin thrice a week for 4. So that was the initial RNTCP regimen into 3 categories. I said DARTS Plus was not there initially because rule was whenever country will be covered, any country will be covered with DARTS, then DARTS Plus will be introduced. So that was the time when it was not introduced. So only 3 from 2003 to 2000, the next guideline came in 2009. And in 2000, and there was no doubt that there was some regimen for drug-resistant TB, but it was not known as the PMDT that time, but chronic or MDR TB, suspected MDR TB, chronic means who failed on initial treatment, category 1 or 2. And in that, I forget one thing, there was another category, category 2. So 1 was more serious, sputum positive 3, and category 2 was sputum smear positive relapse cases, what is known as today recurrent case. Sputum smear positive failure. So sputum smear failure, या तो रिलैप्स हुआ या फेल हो गया. रिलैप्स का डेफिनेशन था, और फेलियर का मतलब who is already on treatment, taking treatment, but he is not responding, that was failure. Sputum smear positive treatment after default. So there were 3 category of category 2. अब तो हम लोगों को भी भूलने लगा है क्योंकि ये सब वर्ड यूज नहीं होते. अब sputum smear negative relapse cases, sputum positive failure cases, and sputum positive treatment after default. Somebody default means somebody took treatment for 2 months and again he came as sputum positive and then they call on default. So all these three categories, they were categorized into category 2 and the regimen at that time was this. 2 months of intermittent thrice weekly in this 4-drug regimen, we have added streptomycin. So that was 5-drug regimen. INH, rifampicin, pyrazinamide, ethambutol, and streptomycin. This was thrice weekly and for 2 months. And then 1 month of, so streptomycin is only for 2 months, and that was thrice weekly. And then for next 1 month, streptomycin was stopped and only the 4-drug INH, rifampicin, pyrazinamide, ethambutol, again thrice a week. And then for next 5 months, the 3-drug, that is INH, rifampicin, ethambutol. This was category 2 regimen of WHO in 2003, when first time RNTCP was introduced. So these are the 3 categories. No doubt that there was nothing like PMDT because DARS Plus was not there, but they were regimen by various books. We have treated many patients even before this for drug-resistant TB, and one of the common regimen was aminoglycoside. Believe me, 6 months injection. We used to give 6 to 9 months. Ethionamide, 6 months. Pyrazinamide, 6 months. Fluoroquinolone was 1 drug, 6 months, and then ethambutol plus minus. That was the regimen being adopted in the country. Some of the patients, but they were only used by the private physicians. They were not in the government. Ethionamide, fluoroquinolone, pyrazinamide, ethambutol. That was one of the regimen came in 2003. And then you know that category 1 and 3, category 1 and then what came, multi-drug resistant, same regimen has been declared here. So there was 4 regimen, category 1, 2, 3, and 4. And then finally, the 2009 guideline. In 2009 guideline, what we have seen that they have given an option whether these drugs can be used daily or on alternate days, depending upon the situation of the country. And in which we have shown you that initially when this guideline started, there was only 3 categories of treatment. One was for sputum smear positive new cases, and in this seriously ill, even sputum negative, but patients were seriously ill. That you can understand how these guidelines have evolved. And then seriously ill extrapulmonary. These are the three patients in category 1. And then there was a category 3. If I go straight, category 3 was the same thing for smear negative pulmonary TB patients, other forms of extrapulmonary non-serious, they were put on category 3. And the only difference between category 1 and category 3 was category 1 consisted of 4 drugs to begin with and followed by 2 drugs. Believe me, 2 drugs, INH and rifampicin. And then the category 3 was in the beginning, in the intensive phase, there were only 3 drugs. So ethambutol was not there in the intensive phase. That was the difference. What you have to understand that if in category 1, it is presumed that bacterial load would be high. That is why they started with 4 drugs. And in category 3, the bacterial load would be less, like pleural effusion was in this category, extrapulmonary less serious. So thinking that bacterial load, so there is no need of the fourth drug. That was the genesis of this guideline. And then we have category 2, means category 2 has got four classes. One is sputum smear positive relapse. If somebody has relapse, I hope you know what do you mean by relapse. Relapse means the patient is who was sputum positive or negative and treated with tuberculosis effectively and was declared cured and gets the disease again. That was the definition of relapse. And treatment failure was the second group, means whom you are treating and person is not responding. Still is positive after 2 to 3 months. That is known as sputum failure, smear positive failure cases. And sputum smear positive treatment after default. Default means somebody you started the treatment, after 2-3 months he left the treatment and he comes again after some time and he again become positive. That is become. So all the three categories were categorized initially in 2003 in category 2. And category 2 was, instead of 4 drugs, they started with the 5 drugs. They have added streptomycin. Biggest, the criticism came that because in tuberculosis we know failing drugs should not add only 1 drug, but that was a criticism. But however, whatever studies were available at that time, so that was 5 drugs for initial intensive 2 months, and then 1 month of 4 drugs minus streptomycin, and then 5 months of 3 drugs. Here it is 3 drugs: HRE, INH, rifampicin, ethambutol. And all the regimens were thrice a week. When we say thrice a week, or when we say intermittent, even in intermittent therapy, thrice a week, twice a week, even a once a week intermittent therapy was known. But only rider with the intermittent therapy was that it should be supervised. That is why it was called as DOTS, directly observe therapy short course. Because of the supervision you have to provide. So that was the beginning of 2003. And subsequently, there was a regimen for even drug-resistant TB also. Drug-resistant TB means who failed on category 2. You given about 8 months of category 2 treatment, and at the end of 5 months, if he has sputum positive, that was known as category 4 in those days. And the regimen by 2003 guideline was, aminoglycosides. Say kanamycin was very important drug those days. Then ethionamide, pyrazinamide, fluoroquinolone, and ethambutol. This is a 5 drug they have added at that time. And these drugs were all for 6 months. Minimum duration injection was 6 months, all the drugs. And then in a continuation phase, you just remove the injection. That is, the kanamycin was the most preferred drug at that time. And then continue with ethionamide, fluoroquinolone, pyrazinamide, ethambutol. I hope I am clear. That was the regimen for chronic tuberculosis. And suppose there is a lot of MDR TB, because those days diagnostic acumen was also not very good. So supposed to be, probably many of them are MDR TB. So that was the regimen. Believe me, I have treated with this regimen with very good effect. Not that they were the bad regimen. At that time, what was available. But in a drug-resistant and MDR TB, it was a daily regimen. It was not intermittent regimen anytime. So in a sensitive TB, either category 1, 2, or 3, this was intermittent, thrice a weekly regimen. But here, in chronic case or MDR TB, it was a daily regimen. And the total duration for you to understand is about 18 months to 24 months. 6 months of the intensive phase, initial phase, and 12 to 18 months, depending upon how the patient. So we have treated many patients with 2 years, even 2 years plus regimen. And believe me, many of the patients have improved. I have reported in many, this is my own publication, we have reported with this regimen efficacy of around 70% in those cases. Time has not permitted me to search, but we have presented in CHEST, in ERS, and then we published in Indian Journal of Chest Disease and showing efficacy of around 70%. So that was about the drug-resistant TB. And then you know that then later on, when I was telling you when category, so there was category 1 regimen, category 2 regimen, same thing, category 3 regimen, and category 4 regimen. So an injection was even 6 to 9 months. Even sometimes I have given even 9 months of injection to many patients. So that was the 4 category was introduced later. And then after, these guidelines, expiry, if you read 2003 guideline, I have read at least 20 times. They have expiry. Like drugs have expiry, so guideline also has expiry. So those guidelines expired and 2009 guidelines were revised. And that was again, you saw in that guidelines, what thinking came, you can give daily or you can give thrice weekly. Both things came. They also started thinking that the regimen may have 4 drugs and then continuation phase only 2 drugs, INH and rifampicin. So when you take previous history from the patient in continuation phase, they may not have 3 drugs. And then WHO also said that if there is INH resistance is high in any country, those countries in continuation phase, they may have 3. That was the genesis of thinking of 3 drugs in a continuation phase. So in 2009, they have started thinking in these lines. That and India was especially, later on I'll show you that in India, in continuation phase today, we have 3 drugs. Because of this reason, because we have a high level of isoniazid resistance in this country. So WHO has advised both the regimen. And then category 2 was continued in 2009 guideline also. But then it was again daily or 3 times, same. 2 months of 5 drug, 1 month of 4 drug, and 5 months of 3 drug. That is, total duration is 8 months. And another issue was, those days was there, if somebody after 3 months of he still is sputum positive, you can continue the intensive phase of 4 drug for another 1 month. That was total duration, instead of 8 months, it will become 9 months. Those were the regimen used in this country very frequently. And then you see that similar things. Then we have also introduced the treatment for XDR-TB in this country. And in XDR-TB, the category that was known as category 5, because category 1 was there, category 2 was there, and category 3 was abolished. And only 1, 2, 4 means MDR, 5 means XDR. And you know the regimens were based on those. When you make a drug resistance regimen, so they say usually you have 4 to 5 drug in intensive new drug, which will be effective. So with these ideas, in XDR-TB, 6 to 12 months of this was capromycin, PAS, Moxie, idosavine, clofazimine, linezolid. These drugs were started being introduced even in 2009. And the TV notification, it's history now, 2012. Before that, there was no TV notification. But 2012, first time Government of India made that TB is notifiable disease. And you must have heard about the standard for TB care in India. Before I should tell this, I must tell you a little history. The first international standards for TB care came in 2006. And that when I still remember I was attending one of the conference it was in Nagpur, I believe. And some of the WHO person presented international standards of TB care. And I stood up and said, we are managing TB like this. So whatever is standards, there were standards for diagnosis, 1 to 6, there are standards for treatment, there are standards for public health aspect, there are standards for social inclusion. So all these standards were defined based on international standards for TB care, which came for the first time in 2006. Then I believe that the international the standards of TB care in India was also introduced, and first time it was made in 2014. There was a very 3-4 days discussion how TB should be diagnosed and treated, and its social and public issues also, and that was made compulsory that everybody, whether government or private, has to follow the standard of TB care in India. And then, the treatment was like new cases, previously treated, drug resistant, was there. So in 2000, based on the standard of TB care in India, these regimens were devised. Again, same regimen, new patient, 4 drug followed by 3 drug. Now the 3 drug. India, now this is the time in 2016 have started. This is a technical guideline for TB management based on a standard of care of TB in India. And then previously treated regime was resumed. That was still there till 2016. And then the fixed dose combinations were introduced in 2016. Weight bands were introduced in 2016. And later on, I think around 17, when this new guideline came, where they have abolished category 2. So in India also, the category 2 was abolished. That was the history.